So it's been quite a while, so I thought I'll do a video on intrauterine growth restriction. Grab your piece of paper and let's go. Hello and welcome to MK's Medical Review Series. My name is Dr. Moses Kazevu. This is a series on my YouTube channel where we will look at medical topics in depth. Today we're going to be looking at intrauterine growth restriction, or IUGR for short. Remember that most of the fetal growth is going to be characterized by two important cellular adaptation changes. We're going to have cellular hyperplasia, which is what's going to be seen at the beginning. Remember, hyperplasia is an increase in the number of cells. Then eventually this is going to be followed by the hyperplasia and hypertrophy. Hypertrophy is just simply increase in the cell size. This is later then going to be followed just by hypertrophy alone. And most of this fetal weight is going to be gained after the 24th week of pregnancy. So 2/3 of the fetal weight gets gained after the 24th week of pregnancy. Keep this in mind. When we talk about intrauterine growth restriction, you can also refer to it as dysmaturity, small for dates, chronic placental insufficiency. This is just simply when the baby's weight is going to be less than 10th percentile of the average gestational age. Remember, this can occur at preterm, term, or even post-term babies, and it's going to be accounting for 1/3 of the low birth weights and the overall incidence of about 2 to 8% in developed countries, with the majority of them being post-term, about 15% of them, as opposed to them being term babies at 5%. Now, there are some literature that actually use the term small for gestational age and intrauterine growth restriction synonymously, but there are some differences between the two. Remember that a child that's small for gestational age isn't necessarily a child that has their growth that has been retarded. And often the babies are just constitutionally small. Everything is small about them. And these neonates are not generally at risks of increased perinatal morbidity and perinatal mortality. And similarly, late onset of pathological cessation of growth may actually produce a baby with typical features of intrauterine growth restriction. And like I said, these are going to have increase in risk of mortality and morbidity. So when you talk about the types of intrauterine growth restriction, they may be divided as non-pathological and pathological. So in the non-pathological, of course, the fetuses will be small, they will be healthy, and their birth weight will be less than 10th percentile for their gestational age. They may have a normal ponderal index. I will show you how you calculate this based on the ultrasound and the birth weight of the child, the certain measurements that we do on the ultrasound. Then they have normal subcutaneous fat, and usually they have an uneventful neonatal course. And on the other end of the spectrum, if it's pathological, which is what we refer to as a true IUGR, this is going to restrict the growth of this fetus. And this is going to be depending on the relative size of the head, the abdomen, as well as the femur. So they can be divided into two main types, type 1 and type 2. Type 1, which is symmetrical, type 2, which is asymmetrical. Most of the infants are going to be at type 2. Now, I want you to keep something in mind. I want you to remember that the brain is a very selfish organ. And generally, if someone has been starving so much, and this actually affects the brain development and the growth of the brain, it means that this starvation or this insufficiency has probably been there for a very long time. So we often see that if this infant or this child is symmetrically small, which is affecting both the brain, the size of the head in comparison to the rest of the body, particularly the abdomen, then generally you have had this thing for a very long period of time, as opposed to if something that is recent, maybe towards in the second trimester or the third trimester, then it's most likely going to cause changes in the weight of the in the size of the abdomen, and the head circumference won't be affected as much. So we have our symmetrical or type 1, which is accounting for 20%. So these fetuses are going to be having this injurious stimuli that are going to be occurring very early in the phase of cellular hyperplasia during the pregnancy. So the total number of cells is actually going to be less than usual. And this form of growth restriction is going to be generally associated with structural or chromosomal anomalies, or even sometimes congenital infections, the torch infections. And the pathological process is going to be intrinsic to the fetus, and it will generally affect all the organs, including the head. So this is something that was there for a very long time in this pregnancy. Then on the other end of the spectrum, we have the asymmetrical or the type 2, which is going to be accounting for 80% of the cases. So here, this is going to be seen if the fetus, there's something that's going to be wrong with the fetus in the later months of pregnancy during the stages of cellular hypertrophy. So the total number of cells will remain the same. It's just that the cells will now be smaller than usual. So the pathological process often is going to be resulting in this asymmetrical growth, and it may be attributed to things like maternal disease that are extrinsic to the fetus. So the diseases that are going to be altering the fetal size are going to be either reducing the utero-placental blood flow, or they're going to be restricting the oxygen transfer, or they're going to be restricting the nutrient transfer, or even reducing the size of the placenta. So you find out that in a symmetrical IUGR, the child is going to be symmetrically small. So the head is proportionally small in relation to the rest of the body. Then in asymmetrical type, you have the head being large and then the rest of the body being small. So here's a difference between the two. So we have symmetrical, which is type 1, and asymmetrical, which is type 2. So symmetrical, they're uniformly small, while as in asymmetrical, the head is larger than the abdomen. Then the ponderal index is normal. So how do we find this? We see the birth weight of this neonate divided by the crown heel length to the power of 3. Then in those that have asymmetrical type, they have a low ponderal index. Then the head circumference, abdominal circumference, and femur length, as well as the head circumference to abdominal circumference ratio and the femur length to abdominal circumference ratio are normal, while they're going to be elevated in asymmetrical, because remember, the abdomen will be much larger than the head will be much larger than the abdomen. Then etiologies of symmetrical type 1 are going to be genetic diseases or infections that are intrinsic to the fetus. Then with type 2, we are going to have this chronic placental insufficiency extrinsic to the fetus. The total number of cells are less because this affects a phase where you have this hyperplasia that's supposed to be going on, and the cell size is normal. On the other end of the spectrum here, the total number of cells are normal with the asymmetrical, but the cells are just smaller than usual because it affects the phase of hypertrophy. So those that have symmetrical IUGR generally have a neonatal course that's going to be complicated with a poor prognosis, whereas those with asymmetrical, they're going to usually have this uncomplicated course with a good prognosis. So what are some of the causes of IUGR and the pathophysiology that is linked to this? So we may divide it as maternal. It may just be constitutional. Just generally, if it's part of the genetics, if this is a small woman, the maternal genetics, they are generally small in their family, or even just the racial background is going to be associated with giving birth to generally a small baby. These babies are not going to be necessarily at increased risk of perinatal morbidity and mortality. We may have maternal nutrition before and during pregnancy. Remember that glucose, amino acids, as well as oxygen are needed for fetal growth, and they may sometimes be deficient during pregnancy. You may have some maternal diseases like anemia, hypertension, thrombotic disorders, heart disease, chronic renal disease, collagen vascular disease, even SLE that may affect the growth of the fetus. Then you may have some fetal causes where there is enough substrate that's coming from the mother and crossing the placenta, but it's actually not utilized by the fetus. Maybe this is attributed to some structural anomalies like cardiovascular, renal, neurotube defects, ventral wall defects, or even other defects. It may be chromosomal anomalies, which account for about 8 to 12%. These are common abnormalities like triploidies, aneuploidies, like trisomy 13, trisomy 18, trisomy 21. And remember, Turner syndrome, monosomy X, is also commonly seen. You may have infections like torch agents. Remember, T for toxoplasma, O for other infections like syphilis, R for rubella, C for cytomegalovirus, H for herpes simplex, and indeed as well as malaria. Then you may have multiple pregnancies. Remember, there may be some mechanical hindrance to growth or excessive fetal demand, the so-called twin-to-twin transfusion syndrome. You may also divide them as placental causes, where there is a poor uterine blood flow to the placenta site for a long time, leading to this chronic placental insufficiency with inadequate substrate transfer. So this may be in conditions like placenta previa, placenta abruption, circumvallate placenta, placenta infarctions, or mosaicism. In the majority of the cases, about 40% of the cases, we actually don't know the cause of intrauterine growth restriction. But remember that the basic pathology in these small for gestational age is because there is a reduced availability of these nutrients in the mother, or either a reduction in the transfer by the placenta to the fetus or a reduction in the utilization by the fetus. So if the brain size is also affected, this child is going to be symmetrically reduced. The brain size and even the cell numbers of the rest of the body, they'll be having symmetrical small for gestational age. If the brain is not really affected, or if this was occurring towards the late aspects of pregnancy, they'll have this asymmetrical small for gestational age. So remember that liver glycogen content is often reduced, and there's going to be some oligohydramnios because the renal and pulmonary systems are affected, and these are going to be contributing to amniotic fluid. So there's going to be a diminished blood flow to these organs. Remember, most of the amniotic fluids in the later phases of pregnancy are going to be mostly urine. So you have the small for gestational age fetus, which is at risk of intrauterine hypoxia, acidosis, and this may actually lead to intrauterine fetal death. So now, how do you make a diagnosis? So we may make a diagnosis based on a clinical assessment. So remember, clinical palpation, checking for the fundal height, the liquor volume, the fetal mass. This may be used for screening, but it's less sensitive. Your symphysiofundal height is what you're actually going to be looking at. Now, remember that when you are dealing with a pregnant woman, especially those women that are roughly between like about 30 weeks, or let me just say 24 to about 36 weeks, generally you should see a correlation between the symphysiofundal height and the gestational age of the pregnancy, such that if there's a discrepancy that is greater than 4 centimeters, that's quite significant, that this may be pointing you towards intrauterine growth restriction. So remember that the symphysiofundal height is going to be measured every time you see this woman in your clinic, every time you see this woman on the ward. So this should be correlating to the gestational age after 24 weeks. A discrepancy greater than 4 centimeters, where you're going to see that the gestational age is maybe, let's say, 36, then the height of fundus maybe is like a 28, then that's a big red flag. So this is a fairly sensitive parameter to use, and it's going to be about 30 to 80% sensitive. You can also have serial measurements, and this is actually quite important to see that this is not continuously reducing. Then the maternal weight gain remains stationary, or sometimes the mother may begin to lose weight in the second half of pregnancy. You should also measure the abdominal girth, which may also show it's not progressing, or the mother actually having values that are falling. You also want to do a biophysical profile, because remember that ultrasound is going to be done to diagnose growth retardation and to identify a fetus which is either symmetrical or asymmetrical. And generally, you have some sonographic predictive values which you're going to be looking at. So the first thing that we look at is known as the head circumference to abdominal circumference ratio. So in a normal growing fetus, your head circumference to abdominal circumference ratio is going to be greater than 1. That's before 32 weeks. Then it's going to be approximately around 1 between 32 to 34 weeks. And then after 32 weeks, it's going to fall below 1. So in someone who has symmetrical intrauterine growth restriction, both the head circumference and the abdominal circumference are reduced. So it means that the ratio is going to be the same. It's going to be normal. Then in an asymmetrical type of IUGR, the head circumference is going to remain large, and that means that your head circumference to abdominal circumference is going to be elevated. Then using the head circumference to abdominal circumference ratio, 85% of the IUGR fetuses can actually be detected. We can also check the transcerebellar diameter, which correlates to the gestational age. Remember that abdominal circumference is the single most sensitive parameter when you're making a diagnosis of IUGR. You want to do your serial measurements of the abdominal circumference, and you estimate the fetal weight, and this is going to be much more diagnostic of fetal growth restriction. Then we can also check the femur length. So remember that femur length to abdominal circumference ratio is roughly about 22 at all gestational ages from 21 weeks up until term. So if you get a ratio that is greater than 23.5, then this suggests that there is some intrauterine growth restriction, and the femur length is not affected in asymmetrical intrauterine growth restriction. The other thing that we're looking at is the amniotic fluid volume. It generally tends to reduce, and it's going to be associated with asymmetrical intrauterine growth restriction. We may get a single deepest pool that's less than 1 centimeter that may suggest intrauterine growth restriction. Then remember that the 4-quadrant technique consists of the vertical diameter of the largest pocket of fluid in each quadrant of the uterus that doesn't consist of any fetal parts, doesn't consist of any umbilical cord. then the sum of these is going to give you your amniotic fluid index, which should roughly be between 5 to 25. So an amniotic fluid index that's less than 5 centimeters is going to be indicative of oligohydramnios. You should also use your ultrasound for anatomical survey to exclude any fetal anomalies by your ultrasound, things like aneuploidies and other structural defects. We also want to get ultrasound Doppler parameters. So your Doppler velocimetry is going to show elevated systolic-diastolic ratio, or there may be some diastolic notch. These are going to be associated with intrauterine growth restriction as well as intrauterine fetal hypoxia. Then the uterine artery, the presence of any diastolic notch is going to be suggestive of incomplete invasion of the placental trophoblasts into the uterine spiral arteries. This also predicts the possible development of preeclampsia, and normally the diastolic flow is going to be increasing as the pregnancy progresses. Then a reduction or absent or even a reverse diastolic flow in the umbilical artery is going to be indicating that there is some fetal jeopardy and there is a poor perinatal outcome. We could also get the Doppler of the middle cerebral artery. There may be an increased diastolic velocity. That's the brain sparing effect, which is often observed in compromised fetuses. Then you may get also a Doppler of the cerebral to placental Doppler ratio, and it's often decreased in IUGR. And remember, when you talked of the ponderal index, this is going to be the weight in grams divided by the crown heel length, which is cubed. Then remember, a ponderal index that's below the 10th percentile is going to be diagnostic of intrauterine growth restriction. So remember that the estimation of this index by the fetal sonography has been made, and a reduction in the fetal facial fat stores has been associated with intrauterine growth restriction. We may use some biochemical markers. You may get an elevation in the maternal serum alpha fetoprotein levels, and even HCG levels in the second trimester. And these are often markers of abnormal placentation, and they are risks of intrauterine growth restriction. Now, what are some of the physical features that we often see of these patients at birth? So the weight may be less than 600 grams below the minimum in percentile standard. The length is going to be unaffected. The head circumference is relatively large than the body in asymmetrical variety, but if it's asymmetrical, it's going to be relatively proportional. Then some physical features are going to be like drying and wrinkled skin because of this loss of the subcutaneous fat. You may get a scaphoid abdomen, some thin meconium. You may get this thin meconium vernix caseosa. You may get a thin umbilical cord. All these are going to be giving this baby like an old man's look. The pinna of the ear has this cartilaginous ridges. The plantar creases are well defined. The baby is quite alert and active and having a normal cry. The eyes are often open and the reflexes are normal, including the molar reflex. Now, what's our approach to the patient? We generally want to get a history. So we want to ascertain the reliability of pregnancy dating. So remember, accurate early pregnancy dating is essential to make this diagnosis of IUGR. You can't make this diagnosis if the woman is not so sure of her dates. She hasn't done an early scan. And remember that an early ultrasound is the most accurate way of dating a pregnancy. So don't change the gestational age based on a late scan that you did, because the late scan can even be off by as much as 1 month. So you also want to get a history of hypertension, vascular disorders, tobacco use, recreational drugs, medications like anticonvulsants or warfarin, previous intrauterine growth restriction, placenta previa in the current pregnancy, multiple gestations in the current pregnancy. When you examine this woman, you check your blood pressure, any signs of malnutrition, stigmata of alcohol, tobacco, or even drug abuse, then a fundal height 3 centimeters or more smaller than the expected gestational age. Investigations, we want to do an ultrasound for the anatomy, the estimated fetal weight, the lipovolume, as well as the anomalies, an ultrasound for growth every 2 to 4 weeks. The frequency is generally going to be depending on the precision of the measurement. Doppler velocimetry of the umbilical artery, if it is available. We screen for the torch infections. We screen for any thrombophilias if this is early onset IUGR or early onset severe preeclampsia, thrombosis, or IUFD. We should consider a fetal karyotype if there are some structural anomalies. And remember, IUGR less than 32 weeks or IUGR less than the 3rd percentile or polyhydramnios are going to be suggestive of trisomy 18. Now, how do we manage this child? So because the treatment is individualized, you have to review the management with your consultant. You can't make this plan on your own. You review it with the consultant. So the plan is going to be dependent largely on the gestational age. It's going to be dependent on the severity of the IUGR. It's going to be dependent on the maternal condition. It's going to be dependent on the fetal condition. So the management is going to be including a comprehensive diagnostic workup. Then the fetuses that are constitutionally small require no interventions. For those that have this symmetrical growth restriction, they should be investigated to exclude any fetal anomalies, any infections or genetic syndromes, and unfortunately, there is no effective treatment for this group of fetuses. Then those that have restricted or growth restriction to the fetus owing to any placental disease or reduced placental blood flow, such as a chronic placental insufficiency, these may be given some treatment, and assessment of the fetal well-being is more critical in the management, as in the majority, there is no definitive treatment. So most deaths actually occur by 36 weeks. So correct diagnosis and timed intervention are actually quite essential. So what are some of the general measures that we want to take? So bed rest is very important. They must be in the left lateral decubitus or left lateral position. We correct any malnutrition by giving them a balanced diet. 300 extra calories per day need to be taken. Then of course we treat any complicating factors like the likelihood that may be likely to produce growth restriction. We avoid smoking, tobacco, or alcohol. Maternal hyperoxygenation, 2.5 liters per minute via nasal prongs for short-term prolongation of the pregnancy. Give them folic acid, low-dose aspirin at 50 milligrams daily in some cases of thrombotic disease, hypertension, preeclampsia, or IUGR. We may also give them some maternal hyperalimentation by amino acids, which can improve the fetal growth if it was due to malnutrition. So this is not helpful if the placenta function is deficient. Then the maternal volume expansion may be useful in improving placental perfusion. Remember that antepartum evaluation, you're going to have the serial evaluation of fetal growth, and assessment of the well-being should be done once the diagnosis is made. An ultrasound ideally must be done every 3 to 4 weeks to assess the biparietal diameter, the head circumference to abdominal circumference ratios, the fetal weight, as well as the amniotic fluid index. Get the fetal well-being. So order a kick chart, of course, a non-stress test, a biophysical profile, amniotic fluid volume. We'll do a choreocentesis of the blood gases, and a Doppler ultrasound parameters that are to be studied. So the timing of delivery, you should consider certain things. Consider if there is any presence of fetal anomalies, the duration of the pregnancy, the degree of growth restriction, any associated complicating factors, the degree of fetal compromise, any previous obstetric history, availability of NICU services, and generally any pregnancy that is above or between 35 to 37 weeks, you should aim to deliver this woman. If the pregnancy is actually below 35 weeks, if it's an uncomplicated mild IUGR, which is quite common, so we employ the general measures to improve the placental function, then we also, the condition may be reserved in some cases, and we can actually allow the pregnancy to continue until 37 weeks where delivery can be done. We want to do our daily kick charts, and of course, we want to have this weekly antenatal visits, a non-stress test or a biophysical profile if indicated, and serial ultrasounds to monitor the growth and LICWA volume. Then for those that have severe degrees of IUGR, we admit them, twice weekly non-stress test or biophysical profile. We deliver them as planned. If there is any fetal compromise, if the lung maturity is actually achieved and there's evidence where you actually check for your phosphatidylglycerol and your lecithin sphingomyelin ratios, then they're greater than 2, then you can actually deliver this woman. If the lung maturity is not yet achieved, then we generally are going to face a problem of lung maturity as well as the growth restriction. So remember that preterm IUGR infants require the highest level of NICU care, and intrauterine transport to an equipped center is actually ideal in such a case, where we can actually give them some steroids to the mother, such as dexamethasone 6 milligrams IM every 12 hours for 4 doses to actually help improve the lung maturation, because corticosteroids are going to be reducing the risk of the intraventricular hemorrhage and other things, other complications that are related to the poor lung maturation. So the methods of delivery, generally we want to consider the severity of the intrauterine growth restriction, the maternal condition, or any obstetric condition. Generally, we can perform low rupture of membranes followed by oxytocin in cases of pregnancy beyond 34 weeks with a favorable cervix based on your Bishop score. Then, of course, if the head is also deep in the pelvis. So your prostaglandin E2 gel could actually be used if the cervix is unfavorable. Then the color of the liquor could be a guide for further management. Remember that delivery should be in an equipped institution where there is this intensive intranatal monitoring. So there should be clinical and electronic monitoring. So ideally, this is a patient that you want to put continuously on a CTG. And you should have this intrapartum monitoring by clinical and continuous electronic or even scalp blood sampling as needed, because you want to, the risk of intrapartum asphyxia is quite high. Then cesarean delivery without trial of labor is actually done when the risk of vaginal delivery are more. For example, if there's any presence of fetal acidemia, absent or reversed diastolic flow on the umbilical artery, or an unfavorable cervix. So here is a schematic on the management of IUGR. Remember here the fetal weight less than the 10th percentile of the gestational age and the type of IUGR. We should exclude any congenital anomalies and the genetic syndromes as well as infections. Then we should have some fetal surveillance that may be there. The different ways of which you can actually have the fetal surveillance are listed here. If the pregnancy is above 37 weeks, we aim to deliver. If it's below 37 weeks, if it's mild IUGR, we increase the rest in the lateral position, give them folic acid, increase the fluid intake, general management, and fetal monitoring until we push them close to 37 weeks, then we deliver them. If there's severe IUGR, then there are two problems, the problem of prematurity and the problem of dysmaturity. So ideally, this must be done in an equipped center with NICU facilities where you can have some fetal surveillance. And if there is a reassuring fetal status, we repeat the Doppler 1 week. So we do ductus venosus and the umbilical vein, Doppler on these. And then if it's a non-reassuring fetal status, we assess the lung maturity with your lecithin sphingomyelin ratio and your phosphatidylglycerol levels. If they are mature, we deliver. If they're not mature, we give them some steroid therapy, either betamethasone. In our case here, we give dexamethasone, then we deliver them. If the center is with limited facilities, then we should ideally refer these patients to a hospital where they can be delivered, and the hospital that has NICU services and this continuous monitoring. Complications include antenatal complications like chronic fetal distress, fetal death, intranatal complications like hypoxia and acidosis, postpartum complications which may be divided as early versus late. Early include asphyxia, bronchopulmonary dysplasia, and respiratory distress, hypoglycemia because of this reduced glycogen stores, hypothermia, pulmonary hemorrhage, polycythemia, anemia, thrombocytopenia, hyperviscosity, thrombosis, necrotizing enterocolitis because there's a reduction in intestinal blood flow, intraventricular hemorrhage, meconium aspiration syndrome, microcoagulation leading to DIC, electrolyte imbalances like hypophosphatemia, hypokalemia, which is due to impaired renal function, multiple organ failure, and this causes an increase in perinatal morbidity and mortality. Later complications, remember that the asymmetrical IUGR babies tend to catch up with growth in the early infancy, but you may get this retarded neurological and intellectual development in infancy. There is an increased risk of metabolic syndrome in adult life. So obesity, hypertension, diabetes type 2, autoimmune thyroid diseases, and even coronary heart diseases they are at much more risk if they are an infant that was born with IUGR. And remember that the low birth weight infants have an altered orexigenic mechanism that causes increased appetite and reduced satiety. Maternal complications, remember that generally IUGR does not cause any harm to the mother, though underlying diseases like preeclampsia, heart disease, and malnutrition may be life-threatening to the mother. I really hope you enjoyed this video on intrauterine growth restriction. If you did, consider subscribing to the channel, hit the bell notification icon so you never miss such amazing content every time I post. To Zambia and beyond, my name is Dr. Moses Kazevu. Until next time, bye-bye.